Good evening. Thank you for joining us. My name is Carver. I'm a clinical application specialist here at Oculus, and welcome to tonight's clinical webcast, Enhancing Scleral Lens Fitting with the OCULUS Pentacam. You have a text box on your GoToWebinar screen where you can enter in questions at any time, and we'll discuss them at the end of tonight's webcast. Our speaker tonight is Dr. Jason Jedlicka. He is a clinical associate professor at Indiana University School of Optometry and the director of the Corneal and Contact Lens Service there. He's a diplomate in the American Academy of Optometry's Cornea, Contact Lens, and Refractive Technology section, a fellow and past president of the Scleral Lens Education Society, and a fellow and board member of the Contact Lens Society of America. He has contributed to multiple textbooks as an author on the topic of GP lenses. He was awarded the GPLI Practitioner of the Year Award for 2021, and I'm very excited for his presentation tonight. And now, Dr. Jason Jedlicka.
Thank you so much, Carver, and thank you all for being here tonight to share this time. It's my pleasure to talk a little bit about scleral lens fitting, in particular, the applications for the Pentacam in the scleral lens fitter's practice. So the three things I'm really going to talk on tonight and specifically spend the bulk of our time on scleral lens fitting procedures. But before we get into that, I do want to talk a little bit about how we can improve the diagnosis and management of corneal disease for our patients. Most of these patients are the ones who are going to end up needing scleral lenses. And so we can do more for them than just fit their scleral lenses. We can also track their corneal disease, whether it be as their primary care provider in terms of their ocular health, or as a secondary opinion, if you will, to those patients who see other providers as well. So we can also give information in that regard. We can be comprehensive caregivers for those patients if, again, those individuals so choose to utilize us for that purpose. So I'm going to talk a little bit about how the Pentacam can be utilized in the scleral lens practitioner's practice for the proper diagnosis and follow-up of those patients. Then we'll talk a lot about scleral lens fitting, using the Pentacam to help with that, to just get to the best possible fits as quickly and efficiently as possible. And that's really what it comes down to is scleral lens fitting. It's about efficiency for you, for your practice, to minimize chair time, minimize remakes, etc. It's also for the patient's efficiency. It's better for them, less follow-ups, less appointments. They prefer that, obviously, and it instills confidence in you as a practitioner, as their fitter, when you do things efficiently and well. They can tell that you really know what you're doing. And then we'll talk just briefly at the end some of the value that the Pentacam has in monitoring the ocular health of those scleral lens patients, those patients that we've fitted. So initially, let's talk again about that, improving our diagnosis and management of corneal disease. So for those of us who want to fit scleral lenses, part of that practice, either a small part or the bulk of it, is going to be managing patients with corneal disease. And so a Pentacam, of course, gives us corneal tomography. The benefit there being is that we're getting a two-dimensional slice through the corneal tissue, and then we're able to construct multiple slices into a 3D representation of that object, as you see in the picture here. And the benefit here is that it really gives us not just anterior corneal shape information, but posterior corneal shape information. And that's really critical when we're going to be managing the wide spectrum of anterior segment disease. So we want to know, again, not just the curvature of the front, but we want to know the elevation of the front, and we want to know the elevation of the back, and this is all important. So again, corneal tomography, the Pentacam, it gives us that. It gives us that shape information, gives us elevation, it gives us the front and back of the cornea. And so again, a large chunk of our patients who are in sclerals are probably have keratoconus, and so we want to, of course, be able to manage those patients properly, especially that cross-linking is gaining more approval for insurances, and so more and more patients are wanting it, but insurances want to see progression in many cases. So we need to be very astute at being able to monitor our patients for progression so that we can get them treated as quickly as possible. This is just an example of a corneal topography using just a typical Placido disc topographer. And you can see that this looks kind of suspicious. There's some inferior steepening on our map. And so the question is this keratoconus or not? And again, the reality is with Placido disc topography, we really don't know. We can say it's suspicious, but we can't know for sure whether this patient really has keratoconus very early stage or not. And so this is where, again, having the Scheimpflug imaging, the corneal tomography really helps us to differentiate. We always want to look at the anterior cornea as well as the posterior cornea to see. Keratoconus, of course, is a disease of corneal thinning. And if we don't see thinning of the cornea, which is leading to ectasia, then it's not an ectasia. And the cornea, when it thins and bulges, it's always going to bulge forward because the intraocular pressure is greater from the inside than the external pressure on the cornea itself in air, in the atmosphere. And so the cornea is always going to bulge forward. And when the cornea thins and bulges forward, that means that the posterior cornea is going to show more elevation change than the anterior cornea in every situation. So, many of us who maybe manage scleral lens patients, we get referrals from other doctors, and that's great. And some of these other doctors have in Pentacam, for example, already, or imaging equipment. And so we think, well, I don't really need this equipment. I have a corneal specialist that refers to me. They already do that. I just fit their contacts. And I would just say to that is, we can do better than that. We can provide, whether it's just giving a second opinion or whether it's giving a better opinion about a patient's condition. And so I just want to use this as a quick example. These are two patients from my practice who both have had laser vision correction. And as you look at just their topographical curvature maps, I think we would all agree that these both look very suspicious for corneal ectasia post-LASIK. And indeed, if we look at patient A, we can see, if we look at the elevation of the front of the cornea, you can see towards the bottom in that orange area some plus 54, plus 53 numbers. And if we look down at the posterior or back elevation map, those numbers are now in the plus upper 60s and 70s even. And so what that says is that the posterior cornea is bowing forward more, and that is basically by definition an ectasia. So this patient indeed does have post-LASIK corneal ectasia. Our second case, though, which looked pretty similar, which does seem to show an inferior steepening. And if we look, though, at this patient, we see that their corneal thickness in the bottom left map is very well centered. And if we look at our front elevation map and our back elevation map, you can see that the high number on our front elevation map on the front, right about in here, if you can see my cursor, plus 30, as opposed to the back elevation is only plus 27. So this patient does not have an ectasia, and they do not have post-LASIK ectasia. Do they have some irregular healing or something wrong with their cornea? Perhaps, yes. But this patient, again, had seen two different corneal specialists and was told by both of them, you have post-LASIK ectasia, you need cross-linking. And the reality is by definition of an ectasia and what we can see under Pentacam, they technically do not have post-LASIK ectasia. So this is just an area, again, where we can provide a high level of care once we understand how to interpret our Pentacams for our patients. And really looking at the posterior corneal data is so critical. So again, I just think that for those of us who want to fit scleral lenses and a volume of scleral lenses, I think we can be that patient's quote unquote corneal specialist in a lot of ways for them. I think we have the capability of diagnosing and managing our contact lens patients just as well as anybody. I think it's certainly within our skill level to be very good at interpreting corneal maps, corneal tomographies, and giving patients good quality care. So I do think, again, a Pentacam has a place in our practice beyond just in it how it will help us fit scleral lenses. It can do everything for us. So I think it's a critical tool in properly diagnosing and managing our potential scleral lens wearing patients. So let's move on then and talk more about how we can use Pentacam to improve our scleral lens fitting, which is really the reason why we're here. So when we go about the process of fitting scleral lenses, there are a lot of ways that we can approach going through the fitting process. This is kind of just tongue-in-cheek, but start in the middle of a fitting set was one way we used to try to do it 15 years ago before we had technology. You just grab the middle of the lens set and start in. Interestingly enough, many years ago, I had a consultant for a lens manufacturer come to my practice, and we did a couple scleral lens fits in our office. And again, this was before a lot of technology, and he just kind of looked at the patient's eyeball and profile and reached for a lens, having a gut feeling about the depth of that eye, and remarkably good guesser in many ways, professional, knew what he was doing. But again, that was a different time where 15 years ago, what we considered a reasonably good scleral lens fit was just something that didn't touch the cornea. And now we have far higher expectations and aspirations for our outcomes than that. We do have fitting guides, and fitting guides are helpful. I mean, they're there for a reason. The manufacturers have obviously put a lot of thought into trying to get you into the right place with fitting guides because they don't want to remake a lot of lenses. So they're trying to help you be efficient. But again, the fitting guides have limitations because there's such a variety of eyes that we're going to fit in scleral lenses. And the things that most of these don't take into account is the corneal diameter and its depth that it contributes and things like that. So fitting guides are good, but again, we can be far more efficient and high quality in our fitting process than that. So again, the problem with these methods is a lot of guesswork, which ends up taking more chair time. And it's not ideal for our practices because that chair time is expensive. It's not ideal for the patients because patients can typically tell when there's a lot of trial and error involved. They can tell that, that one didn't work, let me try another. And they're sitting there scratching their heads going, I wonder if he knows what he's doing, or I wonder if she knows what she's doing. And again, it's not ideal for lens manufacturers either because we're looking at more remakes. And again, in the ideal world where we're properly disinfecting our scleral lenses, where they're sitting in peroxide for several hours between wearings or trials, we just don't have the ability to be putting lots of lenses on our patients' eyes at the fitting appointments. So when we go through the process of picking initial lens, no matter what what style of fitting you're going to embark upon, what methodology you're going to use, an important thing is to know the patient's corneal diameter, because the corneal diameter is going to give us an idea of the lens diameter we need. Clearly, if we're going to fit a lens which meets the criteria for a successful scleral lens fit, it's going to clear the cornea and it's going to not have bearing on the limbal area. And so we've got to fit a lens where the geometry of that lens is such that the transition area where we're supposed to move from vaulting to bearing is beyond the limbal zone. And so again, that requires knowing the patient's corneal diameter, and it requires knowing the lens that we're working with and what that chamber size of our lens is so that we pick the proper diameter. So again, if I have a patient with a large cornea, I need to make sure that the lens diameter I choose has a vaulting chamber that's larger than my patient's corneal diameter by 1 millimeter or so, so that I have room for landing beyond the limbus. I also don't want to choose a lens which is too large, because if I overvault the limbus significantly, it just creates a sloppy fit with lens decentration, more risk of prolapse, etc. So in order to really have optimal fits, we've got to pick a lens diameter which is optimal for our patient's corneal diameter. So we really would love to have accurate measurements of the patient's corneal diameter. And again, so to do that, our instrumentation can give that to us here. You can see on our Pentacam display in the red ring, you've got corneal diameter measurement to the 1/10 of a millimeter. And so again, this is critical information to getting us to the best possible fit as quickly as possible. Again, it's not to say that you can't fit a lens without it, but it's going to require you to do more trial and error as you put on a lens which is either too small or too large, only to recognize it at the time of fitting or later when you're struggling to get a good fit and you can't figure out why. So again, when I personally begin a scleral lens fitting, I want to know that corneal diameter to a 1/10 of a millimeter, and I want to choose a lens diameter where the chamber of vaulting, the part of the lens that's intended to be the vaulting part of that lens, is the right size for my patient's cornea. And so when I put a lens on that patient's eye, I know where that lens is going to land in relation to the limbus, and I know it's going to clear the limbus because I've chosen the proper lens diameter. So the Pentacam, again, can give us that corneal diameter accurately to a 1/10 of a millimeter, so it allows us to choose a proper lens diameter, and that's always the first step when we're doing a fitting process, to know what lens diameter is appropriate for our patient. The second part of the fitting process with a scleral lens, again, is to choose a lens which has the proper geometry for our patient's eye. And I don't know about you, but if I have a patient with a very steep central cone, I'm not going to fit them in the same lens design as a patient who's had, say, LASIK for 8 diopters of myopia, because those are two very different corneas. And if my goal is to fit a scleral lens that properly vaults that cornea in an aligned manner as possible, then I want to choose for my keratoconic patient a lens that has a steeper base curve that flattens as I move towards the peripheral cornea. And for my LASIK patient, I want to have a lens with a flatter base curve that steepens in the mid-periphery and then flattens again at the limbus. So it's knowing the patient's corneal shape is critical to choosing a lens that's going to provide a proper, even amount of alignment. And why is even vaulting important? Because it's all about oxygen permeability. And when I overvault or undervault part of the cornea, I run risks, whether it's with overvaulting leading to lack of oxygen permeability, or undervaulting leading to the risk of touching the cornea and causing mechanical issues. So again, our Pentacam can give us topographical and tomographical shape data. We can also use our Scheimpflug imaging to just simply look at our cornea of our patient. And this is 2 eyes from the same patient. This is the right eye and the left eye of a patient. You can see that the patient's left eye has had intacts placed, which has altered the shape of the cornea and probably driven the apex of their cone into a more central position. Where the right eye, the picture on your left, you can see this patient has almost more of a pellucid look where the thinning goes far to the periphery. And in this case, the apex of the cornea is far outside of center. And we're going to choose to fit this patient in different geometric shape lenses in each eye. The right eye would use a reverse geometry design. The left eye would use a standard geometry design. And that, again, is just the idea of giving me the right amount of clearance where I need it. So beyond the Pentacam helping us choose the right lens diameter and choosing the right lens geometry in terms of creating the most even alignment vaulting as possible, we also have to deal with the shape of the sclera. And we know the shape of the sclera can be very different from one patient to the next, very unpredictable, if you will. Certain things like keratoconus are going to create very quadrant-specific scleras. Patients with astigmatic eyes potentially going to have very toric scleras. So the scleral shape is often challenging to understand without putting a lens on and assessing it. But that again takes up chair time, and it takes the patient needing to have a lens put on and assessed. So is there a better way to understand the shape of the sclera? And of course there is, and that is on the Pentacam, the CSP, the corneal scleral profile output or test, which can be run to give us this elaborate output, which talks a lot about the shape of the eye. It's very useful. So I want to talk briefly about the CSP reports that are generated with the Pentacam. So just briefly, the CSP measurement is actually 5 individual scans with the current Pentacam configuration. You're going to take a central scan, and then you're going to move through each quadrant. The patient looks at the target straight ahead in all situations. We don't have to change fixation. We're going to hold lids, of course, when we're trying to get a scan of the upper or lower sclera. And as you go through the peripheral scans, again, you may need to retract lids. So sometimes we have a technician help with that, or there are little tools that can be useful to help with retracting the lids. And the nice thing is, as you go through the acquisition process, if you do the central scan, if it's a good scan, it will tell you it's a good scan. You can move on. If for some reason the scan comes out and it's not a high enough quality scan, if there's an issue with it, it will tell you that it recommends repeating that scan until you get a good output. That way you don't get to the very end and recognize, gosh, I don't have a very good map. I got to go back and repeat all 5 scans again. So as you work through the 5 scans with the CSP, it does tell you each step of the way whether each of your individual maps is a high enough quality to give you a good image at the end. So repeating an individual portion without repeating the entire process. Again, once we've obtained the 5 different scans, the instrument's going to stitch them together to give us this report. The image on the left, which is your individual 25 cuts through the cornea and sclera all stitched together. The color of each of the arcs represents which of the scans contributed that information to the scan. And so then you can look over to the right, and again, a whole host of information. The first thing I draw your attention to is the area where it talks about the scan coverage. And again, so on the scan coverage, we can see that we have our gray zone in the middle, that's our central scan. And then we have our blue and purple scans, the nasal and temporal, and the green and red scans, the superior and inferior scans. And so the portion of the picture on the left, which is in red, for example, that was contributed to by using the inferior scan data and so on. Once we've got a good quality map and we can see by our coverage map how much data we're obtaining, we're happy with that, and we start looking further at our map, we can see, for example, if you move to the center of the map to the right, there's a bright red box shows you the horizontal white to white, again, helpful in determining the lens diameter that you choose to fit the patient in. Excuse me. Moving to the lower right, we can see the corneal scleral elevation map, which gives you that kind of overview of the shape of the cornea and the sclera all in one shot, recognizing that the cornea and sclera are displayed to you on 2 different reference spheres. And then there's a whole bunch of other things that we can look up above to the right, which is very helpful. We can set a ring diameter, which will give us data at that given diameter of cord that we choose. It will tell us things like the sagittal height of the 2 major meridians. It will give us the slope data of the sclera in that area. So again, a lot of information here that we can use in obtaining a good quality scleral lens design, and we'll talk about that in just a second. So again, one of the things that's really helpful in going ahead and fitting a scleral lens that I like to do as soon as I get a map is I like to look right away at the elevation maps that are in the bottom right corner. And here's just 3 examples that you can achieve. So the upper left picture If you look at this map, you can see that the nasal and temporal sides are quite hot looking in color, where the superior and inferior are quite cool. And so what this tells us is this patient has essentially a with the rule scleral shape, flatter in the horizontal meridian and steeper in the vertical. This patient is going to need a toric lens to get an optimized fit, just because you can see the nature of the toricity just by looking at the map in a glance. If we move to the center map in the lower part, you're going to see, again, a very toric-shaped sclera, but this time the toricity is oblique. So our steep meridian here is going to be from about axis 135 to 45. Our flat or higher elevation meridian is going to be around 45 to 225. And so again, this patient will also require a toric lens to achieve an optimal fit. And so again, before we even begin the fitting process, we know right away that if you've got the option of a spherical or a toric diagnostic set, you need to pull your toric diagnostic set right now. The upper right picture is a different scenario. We can see as we look around that this patient is relatively blue, starting around 1 o'clock and moving counterclockwise to 12, 11, 10, etc., all the way back around to 4 o'clock. We see a fairly even blue color to their map. And so this patient has a relatively spherical sclera, with the exception of the quadrant between 1 and 4 o'clock, where that sclera is more elevated. And so the patient in the upper right picture will benefit from a quadrant-specific design to give them an optimized fit. And so again, this quick snapshot of the corneal scleral elevation map tells us right away, are we dealing with a spherical eye, a toric eye? Do I need a quadrant-specific lens? Do I need a freeform design? Do I need something like a microvault to vault over a very localized elevation like a pinguecula? That all is apparent in just a moment's glance at this map. Beyond that, again, I will just say that if you choose to diagnostically fit your patients with a fitting set, again, how does Pentacam help you? It, again, gives you that HVID so you can choose the right lens diameter. It gives you corneal shape to choose the right geometry. It gives you the sag information at any given chord. Again, you can see as we set that ring diameter in the upper right of the report on the right. You also see down below a box that says Scleral Lens Diameter. And in that box, you can choose the diameter lens you want to fit, put that diameter in, and it's going to give you the sagittal height at the ring average, which you see below it at 3701. So again, this is going to tell you which sag lens is going to give you the best fit for your patient. Again, referencing what we just talked about, it's going to give you general scleral shape information through the elevation map in the lower right to decide what type of lens I need, toric, sphere, quad, etc. And again, if you need something more complex like a quad or freeform lens, it's going to tell you that as well, so that again, you don't spend your time spinning your wheels working with a design that's probably not going to work in the end. If you don't have the CSP, again, you can still use your Pentacam to get an estimate of scleral depth and ocular surface depth. So I want to talk about this. Maybe some of you have a Pentacam in your practice now, but you have not upgraded the CSP, which of course I highly recommend you do, but let's say you haven't. This is just a quick trick that I did for many years before CSP came out. And this is just utilizing a Scheimpflug image of the patient's cornea and measuring the sagittal height at a given chord and then extrapolating from there. So let's walk through this. Here's a picture of a patient. This is obviously a patient who's had a corneal graft, as you can see by the Scheimpflug image. And what we do is, if you look at the upper right picture or upper right portion, you see this green peak that says 38.9 next to it. That green peak is basically the patient's anterior corneal surface. And so what we want to do is we can take our cursor and draw a line, this blue line we've drawn across the cornea. And typically with a Pentacam, we can get about a 14 millimeter segment measured. And so you can see here we've got 13,900, basically 14 millimeters. what we do is we draw this line, and then I will draw a line down from the blue horizontal line down into roughly where I expect the sclera is. And you can see by the drawing here with this blue line, I've gone down below where it looks like the white of the sclera is, and that's just because there's a lot of reflectivity that the sclera gives. And so I know that the sclera is probably a little bit below where that glow is. So in this case on the right, I've got 4,110 microns. If I move over to the left side, again, a different reading there, 4,390. And so what I just do is I average those two values, giving me an average sagittal height on the nasal and temporal side of 4,250 at 14 millimeters. So then you simply go through this process and get out your little sheet of paper and say, well, at 14 millimeters, the sag of the eye is 4,250. If I want to fit this patient in a 17 millimeter lens, for example, I need to add some depth to my lens to account for the extra 3 millimeters that I haven't actually measured. And so we use about 300 microns as a ballpark for each millimeter of size that I want to increase. So if I want to go from 14 to 17, that's a 3 millimeter increase from my measured chord to my lens diameter. And so I'm going to take 3 millimeters times 300 microns, or roughly 900 microns. I'm going to add that back into the measured sag, and then I'm going to add some initial desired vault. So let's say I want a vault of 300 to start with. And I take those three numbers, add them up, and it gives me at 17 millimeters, an initial diagnostic lens should be around 5450 to get the optimal sag. So again, this just helps if you don't have the CSP already. Again, you need it, but let's say you don't have it and you're trying to give yourself an estimate, or let's say for whatever reason, you just don't have the ability to get the CSP data, but you do have the Scheimpflug images, you can obtain the sag data for the eye you're working on using this quick and easy estimate process. Okay, if you do have the CSP, again, this is much quicker once you obtain the scan. So using the display on the right, you can see all of the data that we've been obtained for this patient. What can I get from this display to help me with my fitting? Well, the first thing I can see is that my horizontal white to white is 11.4. This is kind of in the center of the map on the left side. It says 11.4. So again, that directs my lens diameter that I will choose. In this case, given that smaller cornea, I chose a 14.8 diameter lens, and you can choose whatever diameter you prefer. Also, looking at the corneal scleral elevation map, I can tell that this patient has a relatively spherical cornea, and so I chose a standard prolate series type lens, a standard geometry lens. I don't need a reverse geometry lens in this case. Also, I can look at the display where it says scleral lens diameter 14.8 in the center right, and below that it says sag height ring average at 14.8 of 3701. So I want 300 microns of vault, so I'm going to add 300, and that tells me at 14.8, I need a lens with a sag of about 4001. And again, looking at my corneal scleral elevation map, I can see that my eye is flatter or more elevated from about 330 over to 930. And I can see that my sclera is more depressed, or it's steeper or deeper from about 1230 down to 630. So this patient indeed has a toric eye. If I look up above into the upper right corner, you can see the third value down in the list says sag height astigmatism 284 microns. That's quite a toric eye. So again, that's going to direct me to choose a toric diagnostic set. So again, if I have this display and I still choose to diagnostically fit, you should be able to put a lens on the eye that is the closest possible lens from your fitting set 95% of the time, one and done, single lens, put it on, tweak the fit, over refract, and you've got a very good fit with only using one diagnostic lens 95% of the time. Again, here's another example of just using that to do your diagnostic fitting if that's how you choose. This is a patient with a horizontal white to white. If we look of 11.9, At 11.9, I chose to choose a 17 millimeter lens. I also, looking at the cornea, realize it's a normal astigmatic patient. I'm going to choose a standard geometry design. Based on the display, I can see at 17 millimeter ring diameter up above it and a 300 micron clearance, which is in the lower right where it says central clearance 300 microns. This CSP report is telling me to choose a sag height of my scleral lens at 17 millimeters of 5276. So I'm going to go to my diagnostic set, choose a 17 millimeter lens with a standard geometry with a toric design of around 5276, whatever the closest I have in my fitting set is. And again, from that point, I should be able to put a lens on, and with just a single diagnostic lens, I should be able to make my adjustments, over refract, and order a lens that should be dispensable 95% of the time. So again, this CSP report really streamlines even the diagnostic fitting process if that's how you choose to do the fitting, and so that you can just use a single diagnostic lens on the vast majority of your patients and you're done. And again, it is impressive to patients when you put a lens on and it's awfully close from the get-go. They think, well, you really know what you're doing. This lens is really close to what I actually need. If you choose to go the empirical fitting route, if you have knowledge of the patient's refractive error and you feel like you have an accurate measurement of the refractive error, or you know what their prescription was using a prior GP lens, known the base curve and power, you can empirically fit lenses using your CSP report as well. And there are different lens designs that you can do this with. This is just one example. Using this empirical fitting guide, you can choose a scleral lens diameter based on the horizontal white-to-white value. In this case, number 1 says our HWTW is 12. So again, you can choose the lens diameter from that, plug that into cell number 2 where it says scleral lens diameter of 15.4 in this case. Again, whatever diameter you choose to fit, you plug it in there. That's going to tell you in box 3 the sag height ring average at 15.4 is 3920. So I can know right now the lens sag I'm going to order from the lab is going to be 4220. Okay, so that tells me right away the lens sag I need. I've already chosen my lens diameter. Again, I can choose a base curve based off historical values or off of the patient's K readings, which you can also obtain through your Pentacam. And then in terms of choosing my peripheral curves, the bulbar slope, flat, and steep values in box 4 on the upper left, along with a fitting guide, which tells you what those slope values would indicate in terms of steep or flat relative to a standard peripheral curve, would allow you then even to empirically order the peripheral curves and say, I want my lens, 60 microns steep in one meridian by 60 microns flat in the other. So using your CSP, if you so choose, and again, if you have reliable refractive data, you could build your initial lens without ever putting a lens on your patient's eye, and again, be relatively close, whether dispensable or using that as your first diagnostic lens if you wish to, again, to avoid having to use diagnostic fitting sets. So here's another example of a patient. Just walk through this process. Example number 1, we choose a diameter based on the horizontal white to white. In this case, it's 12. I'm just saying with a fitting set I like to work with, I would put a 15.4 millimeter lens on. So I go to box 2, set the scleral diameter to 15.4. It tells me the ring average at 15.4. I add for what the vault I want, in this case 300 microns to get 4220. In this case, my slope values up in box number 4 say 39 by 41. Well, that's pretty spherical. And so in this case, I might order just a spherical peripheral curves, or I could order it with just a very light amount of toricity as well. But again, this allows me to essentially design my lens off of my map strictly. One more example, this is a patient now looking at box 1 with a horizontal white to white of 10.8, a much smaller cornea. In this case, I'm going to fit them in a smaller lens. So I go to box 2, scleral lens diameter 14.8. Moving down to box 3, it's going to tell me the sag height at 14.8 is 3640. I'm going to add a little bit for vault, so go up to 3940. And then using my slope values, I'm going to pick a lens that has 60 microns flat by 120 microns steep, which is what my grid shows me. So again, just a quick way to get a lens very close to the right fit. And if you so choose to avoid, in this era of COVID and disinfection protocols, if you so choose to not use diagnostic fitting processes and instead use empirical fitting, this is one easy way that you can order a lens that should be very close for your patient on the first try. Couple more cases I just want to talk through here before we wrap up. This is a more complex fitting, and it really just highlights the power that the Pentacam CSP can give you when it comes to fitting. This is a patient who just has some naturally occurring corneal astigmatism, 1.75 diopters in each eye, kind of against the rule. Again, not a very common eye shape. One of the things that's really worth noting is that the sclera of the eye tends toward an against the rule shape. What does that mean? That means that if you were to look at 100 patients with spherical corneas, most of them would have an against the rule scleral shape. Not all, but most would. In this case, our patient has against the rule corneal cylinder, which just means that we're probably going to be looking at even more against the rule in the shape of the sclera. So again, this is a patient which is a somewhat tough fit. They've tried soft torics, they've not gotten good quality of vision. Again, corneal topography in this case shows some generally regular corneal cylinder, albeit somewhat oblique and against the rule. When we look at the CSP report for these two eyes, we can see, first of all, on the central image, that this patient has, again, a highly toric cornea and a highly toric against the rule sclera, being elevated more from 11 down to 5 and being steeper between, say, 2 and 8 o'clock. Looking at the image on the right for the left eye, what we can see again is this patient has an elevated sclera at around 1:30 down to 7:30 and a steeper sclera between 4:30 and 10:30. And interestingly, if you look at this, I think this is fascinating. Hopefully you can see my marker here. But what we've got here is this area where the sclera is flattest is a little bit more against the rule than the cornea. So again, the cornea axis, it's shifting to a more against the rule as we move out further onto the sclera, and the other eye does the same. Our axis is shifting a little bit more against the rule as we move out over the sclera, and that's just very typical of the sclera to be more against the rule in shape than our cornea, and we see that time and time again. So let's getting back to this case. This patient, the corneal diameter is around 11.8, 11.9. I had chosen to fit them in a 17 millimeter lens. So just walking through the step by step, using the data that the Pentacam has given me, it's directing me to a sag on the right eye of 5300, a sag on the left of 5250, base curves, powers plano in both eyes. My peripheral, the sag height astigmatism value here is very high. 542 microns of toricity in the right, 560 in the left. That's a lot of toricity. So we ordered the patient lenses that were essentially 540 and 560 microns of toricity in the periphery, thinking, well, we've got really good data, these should be really close. And indeed, if you look at the lens fit, it's not bad, but what we've still got here, despite our best efforts, is we've still got a lens which is flat up around 10 o'clock. It's got edge lift. And so this is already made as steep as I can make it, and I still have edge lift. On top of that, you can also see that the lens is decentering inferiorly pretty noticeably, and it just really doesn't fit the shape of the cornea very well either. So one of the things that we can do is we go back to our Pentacam and recognize that we can change our ring diameter. In this case, I changed the ring diameter to 13.6 millimeters, which gets me closer to the area where the lens is landing on the eye. And at 13.6, I can see that my toricity here is already 222 microns on the right, 247 on the left. And so what this information gives you is it allows you to go back to your lens design and say, hey, I need 540 microns of elevation difference in my lens, but I don't want all of it just in my scleral zone, because a good bit of the toricity in this eyeball is in the cornea, not in the sclera. So I go back to my lens manufacturer and say, hey, I need toricity built into the internal aspects of this lens. I need some toricity built in to the vaulting chamber, so that when this lens lands on the eye at around 13.6, I'm touching the eye 360 degrees around. I'm not vaulting off in one meridian. So again, there's different ways of referring to this lens, but again, it's essentially taking some of that toricity that you're putting in your scleral zone and moving it inside your vaulting chamber so that you get more alignment over the limbal zone. And so again, by doing that, in this case, putting about 250 microns of the sag difference in the internal aspects of the lens, and then only needing to put 300 of it in the peripheral curves. Now what you see is we've managed this area up here to lay down nicely with the sclera, and we've centered the lens a lot better now compared to where we were before. And we've just got a much more appropriate looking fit. And what's the key to getting this fit is to go back and recognize that with my Pentacam, I can change my ring diameter to anything in the world I want, and I can look at the shape of the eye at any diameter I want and understand how much toricity and how much sagittal height I have at any given chord. And so that can properly help me to understand what's going on with the shape of my eye. And I think over time, we're going to see, again, more and more toricity being built into the internal aspects of our scleral lenses instead of trying to cram it all into the scleral zone. And again, the only way to really do that successfully and efficiently is to have this ability to measure ocular surface toricity at a given ring diameter of your choosing. So again, this is just an example. The picture on our left is a lens that was just strictly designed by putting all of the toricity in the scleral zone. The picture on the right, understanding now that we can figure out how to add toricity to the internal parts of our lens. And by going back to our Pentacam and pulling that data out, we're able to get a lens that centers much better. I'm sure you can see the picture on the right, it centers much better. We also actually lay down flush with the sclera all the way around, so just a much better fit than the picture on the left. So finally, I just want to wrap up by mentioning that you can also have software-based fitting options with your Pentacam. The Wave and the ScanFit Pro just being a couple of them. And this is just a brief case I want to show you. This is a patient of mine who was wearing scleral lenses for keratoconus and had chronic problems with fogging. And again, as you can see by this fit, where I've got my yellow arrow drawn, you can see a channel of fluid flowing through there. And try as I might, was unable to really effectively seal this channel off, and so that she wouldn't have the fogging. So I said, you know, we're going to have you wash out of your scleral lens for a few days. I'm going to redo your scans, and I'm going to order you a custom freeform design based off of a software program. So again, going back, you've seen this map before I showed you earlier. This is our patient's eye, and this is a patient who, again, has one quadrant there between, 1 and 4 o'clock where the eye is elevated. And then the rest of the eye is more spherical. So why were they getting leaking around 1 o'clock? Well, again, if you look at the yellow arrow, you see this is the area where we transition superiorly from the deepest part of my map up there where it says negative 150 to an elevated part of my map. And my lens was just lifting off in the zone around 1 o'clock because the quadrant nasal here was pushing it up. So what we did was we again went back and said, hey, we need a quadrant specific lens that's flatter over here between 1 and 4, and then steepens up all the rest of the way around. And by using a software-based design, we were able to build that lens effectively. In this case, we use the wave design, which creates a quadrant specific or even a free-form design. And in this case, we were able to get a fantastic fit where we were able to eliminate the patient's symptoms of the fogging and better align the eye up in this zone where previous lens designs had failed to properly align. So again, you have with Pentacam the opportunity to use these software programs to really get to, again, very optimized fits very quickly and very effectively, especially in this era of trying to minimize diagnostic lens use. So again, our final thing that Pentacam can do for us for our scleral lens patients, just a couple of examples of going in both directions. This is a patient of mine who was in scleral lenses and comes back in saying, you know, I think my vision's getting kind of foggy. And I look at the lens and the surface looks okay and there doesn't seem to be a lot of debris in the chamber. Luckily, I had done a Pentacam on him prior to fitting a few years back, and then he comes in 2 years later with these complaints. Well, we repeat his pachymetry and see that he's getting corneal edema. And so we repeated another day and indeed found that he was consistently getting corneal edema with his scleral lens wear. We attempted to refit him in a corneal GP, but he opted to essentially go uncorrected in this eye up until about 2 years ago. He actually underwent a DMEC procedure on his graft, and which resolved his deficient endothelium, and he came back a year ago now and was refitted successfully with a scleral lens. But having that baseline Pentacam allowed us to monitor for changes like corneal edema that would indicate that the patient was not doing well with their scleral. And the other way, again, we talked about earlier, especially with keratoconus, is checking for thinning of the cornea over time. When we have patients who have keratoconus and we see that they're progressively thinning or they're progressively getting steeper on the posterior elevation maps, this is a way to not lose track of our patient's ocular health, even as we're trying to provide them with the best possible scleral lens wearing experience. So having baseline Pentacams and tracking them over time for thinning or for thickening of the cornea due to whatever reason is a really important way to make sure that we're not just fitting our patients and forgetting about their ocular health, that we're taking control of that part of it as well. So again, you know, the Pentacam is such a powerful tool, and it's for the scleral lens practitioner. It allows us to manage their anterior segment disease better, giving them a full service experience. It allows us to make better scleral lenses, whether it's through just using the data to pick a better diagnostic lens and get to happy faster, whether it's picking the data from our CSP and creating more exotic lens designs like adding toricity and things like that to our vaulting chamber, whether it is using software applications that can provide us with sophisticated lens designs rather quickly. All of those things are at your disposal with the Pentacam. So you really can practice to whatever level of scleral lens fitting you want with this instrument. You also are then going to be able to monitor your scleral lens wearing patients for any related complications or any changes to their anterior segment disease over time, which again is very important because we still are learning things about scleral lens and the impact on the eye. And we want to be able to make sure that the lenses we fit our patients in, not only providing them with good vision, with good comfort, but are healthy for their eyes to use. So the Pentacam is really gives you the full spectrum of managing your scleral lens patients, from baseline data to fitting them with scleral lenses to monitoring their ocular health over time. So with that, I am wrapping up this presentation, and I'm happy to take any questions that may have come up.
Wonderful. I really enjoyed your presentation, Dr. Jedlicka. There was a lot of information in there, and I'm definitely going to be rewatching it and taking some more notes. But while we have this time left, go ahead and put your questions into chat, and we'll try and get those answered with what time we have remaining. We might go a little bit over, but we'll try and get what questions in we can. So the first question that I'm going to ask is something that you actually mentioned during your presentation, washing out your patients before taking new scans. How long do you kind of optimally want to wash out your patients for before taking new Pentacam scans, and what's kind of the minimum amount of time?
Yeah, that's great. So to me, the minimum amount of time is 36 hours. And the way that works out for a patient is, let's say they're going to come in and get scanned on a Wednesday morning. I usually say, when you take your lenses out Monday night, leave them out, don't wear them at all Tuesday, come into your appointment on Wednesday, having not had them in since Monday night. We did a little bit of a washout study a couple of years ago, and we tracked patients daily for 5 days, I think. We did this with about 7 or 8 eyes, where we washed them out of their scleral lenses. And we found that there continues to be change probably into about the 3rd day, but the difference between, say, day 2 and day 3 was within the tolerance, if you will, of normal fluctuation in maps.
Mm-hmm.
So I think that the bulk of the shaping effect wears off literally within 2 days. So ideally, I pretty much am at the point now where I tell patients I want you out of them for 36 hours. There's not an ideal or a minimum. That's just what we tell everybody.
All right, perfect. That makes a ton of sense. All right. So I had a few questions about how you chose kind of your scleral lens diameter and a bunch of your examples. You mentioned that it was based off of your horizontal visual iris diameter, but then how did you end up with like a 14/8 lens or like a 17mm lens? What
Sure.
brought you to those decisions?
Yeah, so that's going to go back to the lens design you're working with. So if you've got a lens design you're working with, and I'm not promoting any one design here because they're all really great. I mean, you can be successful with basically whatever design you're comfortable working with. It's just really understanding that design and knowing how it works. And so if you're using lens A, and lens A comes in 3 different diameter or 4 different diameter options, you should understand the differences in those diameters. So for example, if a lens comes in, let's say 15, 16, 17, and 18mm designs, I would call my lab and say, hey, tell me the diameter that this 15mm lens lands at. Does it land on the eye at 12.6 or 12.8? Or what's the diameter where that lens lands? And then how about the 16? How about the 17? How about the 18? And then I want to understand those designs so that then I can go back and have this kind of rule of thumb that says, hey, if I got a really tiny cornea, I'm going to fit a 15. If I got a medium to small, I'm going to fit the 16, medium to big, the 17. If I got a jumbo cornea, the 18. So I picked them just because I'm trying to avoid promoting lenses too much, but it's just that whatever design I chose to fit that patient in, I chose the appropriate diameter option that design comes in based on my patient's corneal diameter. So that, again, that's a conversation with the consultants at your lab and say, hey, help me out. I got a big cornea here. I got a small cornea. How do I steer my diameter given that fact? And then once you've done that a couple times, you should have a feel for the diameter that's appropriate for your patient just by your experience.
Absolutely. Thank you so much for that in-depth advice. Next, I have a question that actually comes up fairly regularly from doctors that are used to fitting with diagnostic lenses, which is empirically, how can I determine the base curve for a scleral lens?
Yeah, so that's a great question. And I, again, obviously it's a lot easier if you're working with a fairly regular cornea, because a simple rule of thumb would just be to say whatever my mean K is or something like that could be the base curve of my lens, recognizing that scleral lenses have a lot of forgiveness for base curve. You could pick the flat K, and that way you also kind of know the power of the lens you need. So if my patient's Ks are 42 by 44, if I pick a base curve of my lens that's 42 and I just fit them to the flat or the spherical power of their cornea, of their refraction, then again, that should work. The problem, of course, is when you get into like an advanced cone or something that's very irregular. And in those cases, again, it just comes down to probably going off of the K readings that you're getting with your Pentacam output. You can just use K readings and, again, an estimate. Now, most of our advanced irregular cornea patients, fortunately have some GP lens wearing experience in their lifetime. So hopefully in our chart somewhere it says, their previous lens was a 6.5 base curve minus 14 lens. And so having that data, you can then extrapolate and determine the power and base curve of your scleral lens. But I think, again, just going off the patient's K readings, and again, if you've got a reasonable refraction, you can calculate that. It won't always work that way. Sometimes you have to take a bit more of a shot in the dark, or actually have to put a lens on and determine what the patient's best base curve and power is.
Absolutely. All right, what are the most common changes you make after fitting your first diagnostic lens with the CSP report?
I feel like it almost always comes down to tweaking that scleral zone. Adjusting central sag is real easy. I probably do that a lot too, but that's just being nitpicky. There's a difference between a lens that's dispensable and optimal. And if in my initial go around, if I get a lens ordered on the first try that I consider to be dispensable, I'm happy with that. And so a dispensable lens might have 350 microns of clearance instead of 300, or it might have an edge that's a little bit flat, or the prescription might be off by a half diopter, but it's dispensable. So when it comes to just initial fitting, I'm always adjusting the sag just a little bit up or down, 50 microns. I'm always adjusting the edge a little bit. When it's coming back to following that patient up at follow-up 1, 2, 3, what am I adjusting mostly? Again, I'm adjusting the scleral zone. I'm trying to get that lens to lay as flush with the eye as possible so that we minimize any lens awareness, we minimize any debris flowing under the lens, etc. I would say most commonly, I'm rarely adjusting the sag after my initial order, because usually you can get that pretty close off your initial fitting.
Perfect. All right, I think we have time for maybe one final question.
Okay.
And when fitting lenses, you talked a lot about kind of the quadrant specific elevation and looking at that elevation map. Do you use kind of the quadrant specific bulbar slopes at all?
Yes. My first thought again would be to go to the picture, the elevation map, and see if my gut looking at that map tells me they probably need a quad specific. And again, how do I know that? It's usually because one quadrant is quite a bit different than the other three. Or for example, maybe I have a fairly toric looking eye, but I can see that one of my two steep meridians is much steeper than the other. If I know I'm going quadrant specific based off my elevation map, then often, yes, I'm going to go up and look at those slope values, and I'm going to allow those slope values to direct how much quadrant specific effect that I'm going to put into that lens. So again, let's say that a lens, let's say my CSP report says there's 250 microns of astigmatism. And so then if that's the case, I'm going to look at my map, and I may, instead of just doing 250 microns of astigmatism, I might have one meridian being symmetric, but I might have the other meridian being asymmetric. So I think, again, the bulbar slope readings can direct you in that regard, and they're helpful, but also think you want to make sure that your elevation map gives you the same advice as your slope map does.
Mm-hmm. Perfect. That makes a lot of sense. And I think everyone listening tonight has learned a lot about fitting scleral lenses, especially those complicated cases were quite interesting. I'm definitely going to be taking a second look at those. So thank you so much for your presentation, Dr. Jedlicka. And thank you everyone so much in the audience for attending tonight. Do you have any last words, Dr. Jedlicka?
I would just, again, encourage everybody to, even though equipment can be an investment, the difference it makes in how you practice and fit these lenses, it just changes how you do it in such a way you add that efficiency, you change the complexion of your practice by being more efficient and practicing at a higher level. So I would just say that the equipment is what really brings kind of joy to the fitting process in a lot of ways to me.
Wonderful. On behalf of Oculus, have a good night, everyone.